if I get on. Good afternoon, everybody, and I want to welcome you to Cardiovascular Medicine Grand Rounds. And it's a real pleasure today to introduce somebody to you who I've known for a decade, as we were together years ago at the University of Rochester, but a lot has changed in that past decade. And I want to introduce to you Dr. Himabindu. She received her medical degree from Northwestern University in Illinois and completed her residency, cardiovascular disease fellowship, and advanced heart failure fellowship at Northwestern. She is currently an associate professor of medicine and medical director of mechanical circulatory support at the University of Pennsylvania and medical lead for mechanical circulatory support across Penn Medicine. Her research interests are related to telehealth and remote monitoring in left ventricular assist device recipients. Dr. Vidula's research currently is supported by 2 NIH R01 grants, which fund multi-center studies related to blood pressure management and exercise in LVAD recipients. Dr. Vidula was previously medical director of heart transplantation, founder and co-director of the comprehensive sarcoidosis and amyloidosis programs, and program director of the Advanced Heart Failure and Transplant Cardiology Fellowship at the University of Rochester in New York. She has been the upstate governor of the New York chapter of the American College of Cardiology and a member of the ACC Board of Governors Steering Committee. She is currently chair of the ACC Board of Governors and a member of the ACC Board of Trustees. So it's a real pleasure today, Dr. Vidula. Thanks for joining us.
Thank you, John, for that kind introduction. And, thank you everyone for inviting me today to give grand rounds here. It really is an honor. It's been great meeting a number of the faculty members last night and again today. And I look forward to meeting others of you after this talk. So my disclosures are here. So I grew up in the Chicago suburbs, so not too far from here. And I remember when I was growing up in middle school, my dad, who's an electrical engineer, cut out this article for me because he thought it was really interesting that people were putting mechanical heart pumps into patients. And so in '95, this 16-year-old waited for 16 days on a C70, which is a modified version of the Jarvik heart, at status 1. And every day he asked, how long do I have to wait for my heart? And he received a heart transplant, but he unfortunately died at the age of 32. And I think this case illustrates many of the issues that we face even today in the world of heart transplantation and advanced heart failure. So heart transplants don't last forever. And ideally, we have an improved pump that allows patients to live with a good quality of life, reduced risk of adverse events, improved survival, so that they can be bridged to heart transplant and they can start that clock later on to increase their overall survival. So today we do have a better pump. Okay, and you guys are very familiar with the HeartMate 3 pump. As you know, this pump was created to improve hemocompatibility, which means it was created to reduce the risk of thrombosis, bleeding, and stroke. And it does that. It has wide blood flow passages that reduce shear stress. It's frictionless, it's magnetically levitated, no mechanical bearings. And it also has this intrinsic pulse, which almost acts like a washout for the pump to help reduce the risk of stasis and thrombosis. So not only do we have a better pump, we also have better outcomes. So when we look back to '98, the rematch trial HeartMate XVE, survival at 1 year was only about 50%. And now here with the Momentum 3 trial and the HeartMate 3 device, we have survival at 1 year nearing 90%. But increased use of LVADs as bridge to transplant has really been unable to be implemented due to the changes in the 2018 heart transplant policy. So as many of you are very well aware of, because we're living this every day, this new policy allows us to optimize waitlist mortality. So it's created to really prioritize those who are on temporary MCS devices so that they get transplanted more quickly. So in this new system, we see that patients are more accurately stratified by waitlist mortality. We see a reduction in patients who are dying on the waitlist. However, as a result of the changes, LVAD patients on durable HeartMate 3 support, in the majority of those patients, unfortunately have to wait longer periods of time. They really can't be transplanted until they have an adverse event. And so this also affects their post-transplant survival. So today we're going to talk a little bit about MCS as a bridge to transplant and how we can potentially optimize outcomes. So we'll talk a little bit initially about outcomes. We'll talk about how we can improve patient selection, how we can optimize these patients before transplant, and finally, how we can think about our donor strategy in this population. So first, let's talk a little bit about outcomes. So in the new era, as you all know, we're using more temporary MCS devices. So at Penn, where I practice in the Northeast, we have some of the longest waitlist times in the United States. So patients have to wait 2 to 3 months on an Impella device before they can be transplanted. And so in this study, you can see, across the United States, compared to the prior system, which is in blue, in the new system after 2018 in red, you can see that there's an increased use of balloon pumps, ECMOs, but a significant reduction in durable LVAD therapy. So previous to the changes in the transplant allocation system, about 40% of patients who were transplanted were bridged with a durable device, with an LVAD. Now that number has decreased by about 40% to only about 25% who are bridged with a durable LVAD. But some systems like ours, who have accumulated a lot of patients with a VAD, we currently have on our wait list, about 40% of the patients on our wait list do have a durable LVAD. So we continue to need to think about strategies to get those patients transplanted successfully. So these changes in the allocation system occurred, and overall survival did not change. So we can see that, in this data from UNOS, pre-policy change, which is in blue, 1-year survival after transplant was about 91%. And post-policy change we see in all comers, 1-year survival is very similar, around 91 to 92%. However, we're starting to see a signal that these increased waitlist times are affecting post-transplant outcomes. So we have an increase in patients who are on temporary MCS, balloon pumps, Impella devices, causing a lot of waitlist congestion throughout the country. That's prolonging wait times, reducing the probability of transplant for these patients. And as they accumulate adverse events, so as they accumulate, thrombosis, stroke, other complications, that can negatively impact their post-transplant outcomes and increase mortality. And we see this in our LVAD population as well. So on the left, you see waitlist outcomes in patients who have a HeartMate 3 LVAD at the time of listing in the current era. And you see that pre-allocation system, post-allocation, there is no significant difference in waitlist outcomes. However, when we look at post-transplant survival, we see that there is a reduction in post-transplant survival. So pre-allocation survival in patients who had a HeartMate 3 LVAD who were bridged to transplant was about 94% at 1 year. And now we see with the allocation system changes, that survival rate at 1 year has decreased to 87%. So why is this? These patients are waiting longer. They can't be transplanted unless they have an adverse event. So unless they've developed GI bleeding or right heart failure, significant aortic regurgitation, they're unable to be transplanted. And unfortunately, as a result of those adverse events, that affects their post-transplant survival. So what can we do about this? So one is thinking more about patient selection. So when I first joined the University of Pennsylvania 2 years ago, I told my team that our new motto is right time, right therapy. Okay, so we're really going to try to identify patients earlier when they're less sick. So when we're thinking about patients who are candidates for advanced therapies, LVAD or transplant, we really want to look at a number of triggers, which you're all familiar with. So when we're getting to the point where we have to down titrate guideline-directed medical therapy because patients can't tolerate it due to low blood pressure or renal dysfunction, if patients are having frequent hospitalizations, we know that 2 heart failure hospitalizations within 1 year are associated with a 40% increased risk of mortality in the subsequent year. If patients are having recurrent arrhythmias, defibrillator shocks, if they're having signs of worsening end organ function, renal function, hepatic function, this is when we want to refer them for advanced therapies. We want to see these patients earlier so that we can get to know them. We can develop a relationship with them. We can identify any psychosocial risk factors. We can help them with life planning. We can also work on their diabetes, on their pulmonary hypertension, on their obesity, on substance use, and really help them become better candidates for advanced therapies. We want to avoid waiting until patients have developed severe malnutrition, cardiac cachexia, because we know that these patients will not do well. So we know that not only does patient selection and the severity of illness affect short-term outcomes, but it also affects long-term outcomes, even at 5 years. So this is data from the INTERMACS registry. So you see INTERMACS 1 is the patients who are sickest before getting a HeartMate 3 LVAD. So these are the patients in critical cardiogenic shock, those who are on ECMO or on Impella with very high dose inotropes. And you see that they have lower survival, those in the blue, compared to the less sick patients, not only at 1 year, but also at 5 years. So earlier referral is associated with better short-term as well as long-term outcomes. So with this strategy at Penn over the last 2 years, we've been able to significantly increase our VAD volume. So we went from about 25 LVADs a year to in the last year, 60 VADs a year. But not only are we concerned about numbers, more importantly, I'm concerned about outcomes. Okay. And so this is, these are 3 pie charts showing over time the change in INTERMACS profiles at our institution. So red is INTERMACS 1, those sickest patients, the ones I told you on ECMO or Impella with very high dose inotropes. Now, pink is the ones who are just on an Impella. And we really want to target those patients in blue. So we want to increase the amount of blue that we see in these charts, because those are the patients who are on inotropes alone, INTERMACS 3, or just on guideline-directed medical therapy patients in group 4. Okay. And as you can see, we've really been able to shift that curve. So when we first started with this therapies and with this motto, we were only about 24% of our patients were in INTERMACS 3 or 4. And now we've moved to the point where more than 50% of our patients are in that INTERMACS groups 3 and 4. And with this, we've seen a 50% reduction in our index hospitalization mortality. Now our survival is above national average immediately post-discharge, but also at 1 year. We have been able to reduce our length of stay significantly and halved it so that it's below the national average. And really, this is a result of improved patient selection. So not only do we want to think about the right time for referral, but the right therapy. So when we're trying to determine whether a patient should go for heart transplant or LVAD, there are multiple factors that we think about in our selection meetings, which you all are very familiar with. So if patients need multi-organ transplants, they're bleeders, they tend to have any congenital or restrictive cardiomyopathies, they don't have great RV function, significant ventricular tachycardia that we're not able to control, these are the patients who do better with heart transplant. But then those who have pulmonary hypertension, obesity, perhaps a potential for recovery, particularly those younger patients who may have presented with a non-ischemic cardiomyopathy or myocarditis or recent cancer. These are the patients that we're moving more towards an LVAD. And in general, for those of you who see patients longitudinally in a VAD clinic, you know that those patients who have good RV function, those are the patients who can really do well in the long term for a number of years. So we really spend a lot of time thinking about that, and can a patient do well in the long term? And I think, we have to think a little bit more about our younger patients. So this is, recent data that came out of INTERMACS, looking at the younger patients less than 50 years of age. And we see that at 5 years, this younger group of patients has a 73% 5-year survival, which is amazing, given that in all comers who get a VAD, the 5-year survival is about 60%. But in this younger group, we're seeing a significantly improved survival at 5 years. But not only do we see improved survival, we also see that at 1 year, 94% of these patients are free of stroke, almost 85% are free of bleeding, and 97% free of device malfunction. So not only are these younger patients doing better, they also have less risk of adverse events. And when the group looked at this stratified by multiple variables, gender, ethnicity, social support, psychosocial risk, race, they didn't see any significant differences. So this is a group, again, where we can be thoughtful about which strategy we use. And in the right candidate, patient who is younger may do well with getting an LVAD, continuing that therapy for a couple of years, and then getting transplanted later on to improve their overall survival. So there are a number of risk scores that can be used when we're looking at patients. Many of you are probably familiar with the HeartMate 3 risk score, which is, looking at initial 1 year and 2 year survival. I know your team has also developed the Michigan risk score for GI bleeding. The Utah group has risk scores for RV failure. So, multiple different scores that can be used at selection meetings to help guide our decision making. But when we're thinking about patients being bridged with VAD therapy to transplant, we're also very interested in their long-term mortality. And this score came out of the Momentum 3 trial. And they looked at not only pre-implant factors, but also post-implant factors. And pre-implant renal function, having, prior cardiac surgery, and post-implant developing worse renal function, having any index hospitalization arrhythmias, having any of those hemocompatibility-related adverse events, stroke, bleeding, thrombosis, all of those factors were associated with reduced 5-year survival. So this is something else that can be used not only pre-implant when we're thinking about, is this a patient who could be bridged to transplant, but also post-implant when we're working on discussing with our patients and trying to make a long-term plan for a patient. We can also use other scores like the HeartMate 3 bridge risk score to determine who are patients who will do well with transplant. So in this score, there are a number of factors that are associated with poor survival after transplant among HeartMate 3 LVAD recipients. And those include older age, having an ischemic etiology of heart failure, having worse renal function, poor functional status, elevated BMI, and elevated PVR. And I've highlighted poor functional status and BMI because these are areas that we can target in our VAD clinics to really help make patients into better transplant candidates. But when we think about bridging patients with an LVAD to transplant, we also have to remember that these patients often have a higher risk of primary graft dysfunction. And there are a number of factors that affect this, including the fact that this is a more prolonged surgery. You have to explant the LVAD, implant the new heart. Often these patients will require more transfusions, which can cause more of a pro-inflammatory state. Often the fact that they are on continuous flow for a long period of time can lead to change in neurohormones and how they respond to pressor therapy, leading to more vasoplegia. And there are other factors that also increase the risk of primary graft dysfunction, including amiodarone use. So as much as possible in our LVAD clinics, we try to minimize amiodarone use post-VAD therapy if patients are stable so that long-term they can become better candidates for transplant. We also want to optimize their renal function because we know that also is associated with primary graft dysfunction. And finally, unfortunately, late right heart failure is also associated with primary graft dysfunction, potentially due to the inflammatory response to systemic venous congestion and hepatic congestion. And this is unfortunate because this is often the population, those patients with right heart failure are the ones who are prioritized more for transplant. We're able to list them at a higher status. But unfortunately, this also means that despite the fact that they could get transplanted faster, they may have worse outcomes. So other issues that we deal with, and many of you have probably dealt with this as well in patients who are bridged with a VAD to transplant, is vasoplegic syndrome. And this is always very unfortunate because it doesn't always have a clear mechanism, a clear trigger, but when it happens, it's quite devastating. And there are a number of risk factors for vasoplegic syndrome in this population, including higher BMI, amiodarone use again, and then, multiple intraoperative factors like we discussed. This is a longer surgery. There's more transfusions. And other mechanisms include frailty. And I've highlighted some of them in red because these are the areas that we really try to intervene upon in our VAD clinic to make patients into better candidates. So as much as possible, again, try to reduce that amiodarone use, act upon that higher BMI, try to improve functional status to really reduce that risk of vasoplegic syndrome because we know that's associated with a significant increase in mortality, significant increase in use of post-op ECMO, dialysis, and mechanical ventilation. So as you saw in many of these different risk scores, renal function plays a huge role in determining a patient's prognosis if they're bridged with a VAD to transplant. And so we actually put together a consortium of centers in the Northeast and collected data on their HeartMate 3 VAD recipients and longitudinal renal function. And what we have found is that in patients who have a GFR less than 60, those who have a GFR less than 40, and we divided patients into multiple groups. Patients who don't have diabetes are those who will improve their renal function after VAD implant. So we use that, when we're thinking about, is this patient someone who has renal insufficiency before their VAD? But if they don't have diabetes, then they're more likely to have a 25% improvement in GFR at 1 year, more likely to eventually become a better transplant candidate. So we talked a little bit about patient selection and multiple factors that can help us decide who should get a VAD versus transplant, who might be a good candidate for a bridge to transplant if they already have a VAD. But what can we do to optimize these patients? So one major issue we face in our VAD population is obesity. So a number of these patients have increased BMI before VAD implantation, and unfortunately, that BMI tends to continue to increase during VAD support. And so we really have been working with our team to create a multidisciplinary weight loss team. So working not only with our heart failure cardiologists, but also our bariatric surgeons, our social work and psychologists, physical therapists, dietitians. We make sure that all of our patients in VAD clinic also are able to see a dietitian on the same day within the first month of getting a VAD, and then every 6 months. So we can really focus on weight loss. We also have been using more GLP-1 agonists in this population. And as we accumulate more data, I think that we can continue to expand that use so that we're able to act upon that obesity, make these patients into better transplant candidates. What about medical optimization? So one thing that we've been studying to try to see if we can make patients into better transplant candidates is looking at what is the optimal target blood pressure range during VAD support. And currently, we try to keep patients at a map between 75 to 90. This is based on expert consensus, but this is not necessarily based on clinical trials data. And we looked at, we did some retrospective studies of our own. And we also looked at some of the data from Intermax. So you can see on the left, we have data from the Intermax study suggesting that a MAP less than or equal to 75 is too low in this population. So even after adjusting for other comorbidities, medication use, a MAP less than 75 was associated with an increased risk of death in this population. So it might be too low for patients. We looked at our own data among about 300 patients who had a HeartMate 3 LVAD who had much more frequent blood pressure measurements than those who are in Intermax. And we saw that, again, similar to their findings, that patients who had more drops to a MAP less than or equal to 75 had an increased risk of death as well as stroke, even after adjusting for comorbid conditions as well as medication use. But what is the optimal medical regimen? So this is an area also, again, that we need more data. So this is a study that was published in JAMA Cardiology looking at neurohormonal medications in VAD recipients. And what they found is that patients with a VAD who are able to tolerate a beta blocker, ACE inhibitor, MRA, these patients have improved survival compared to those who are not receiving any neurohormone blockade. But again, we don't know if this is a risk marker versus a mediator. We might actually just be identifying patients who are healthier and who are able to tolerate these medications better. And that might be why they're living longer. So we still need better data on determining what is the optimal regimen in this population. So given these questions about what is the target blood pressure range, what is the optimal medication regimen, how can we better optimize our VAD patients so they do better in the long term, eventually become better transplant candidates, we actually set up the BP LVAD multi-center study, and we recently finished enrollment in this prospective study that's funded by the NIH. So we have multiple sites across the country. Patients go home with a Doppler to measure their blood pressure. They also have an app where they enter their blood pressure, enter any symptoms they're having. And so we collect data on their blood pressures multiple times a week. We also collect data on their medication changes, renal function, other characteristics to better understand what is the optimal blood pressure range in this population to minimize adverse events. What is the optimal medical regimen as well? So as you saw from the previous slides, not only is obesity, renal function an issue in patients who are on VAD support, who we're thinking about for transplant, but frailty is also a risk factor for multiple adverse events, including vasoplegic syndrome. So there have been multiple studies to try to determine the relationship between sarcopenia and frailty and outcomes after advanced therapies. And, one novel marker that has come up was using pectoralis muscle quantity to help risk stratify patients and identify survival after VAD implant. So patients who have lower pectoralis muscle quantity have lower survival post-VAD implant. And similarly, those who have lower pectoralis muscle quantity have worse outcomes after heart transplant. So these patients have more adverse events. They're hospitalized more often. They have longer ICU and total hospitalization length of stay, and they're less likely to be discharged home and more likely to end up going to a skilled nursing facility. So we know that sarcopenia and frailty significantly affect both outcomes after VAD as well as transplant. But what we don't know is how much of that sarcopenia and frailty can be reversed. How can we really optimize patients? We know that cardiac rehabilitation is helpful in this population. We know that LVAD patients who engage in cardiac rehabilitation have better short-term as well as long-term outcomes. But despite the fact that about more than 90% of LVAD recipients in the US are referred for cardiac rehab, only about 30% actually participate and complete the entire prescribed regimen of cardiac rehab. And that's due to multiple factors. Some of it is access to care. Many patients don't live near centers that are able to provide them with cardiac rehab for VAD recipients. And often these patients have high rates of healthcare utilization. So they already have a lot of different appointments to come to. It's hard for them to fit in cardiac rehab into their schedule, make sure that they have a support person who's able to perhaps drive them there. So as a result, we thought about using home-based exercise rehabilitation in this population, because home-based exercise rehab can give us the opportunity to start exercise earlier in this population and also make it more convenient for patients. So we did a pilot study called the Move LVAD pilot study, and we had two groups of patients. So one was the usual care group, one was the home-based exercise rehab group. And so you can see on the left that patients in both groups received an activity watch, a Garmin watch like a Fitbit, and then they downloaded an app that we had created for the study and were able to see their daily steps. But then patients in the home-based exercise rehab group, they also completed surveys rating their perceived intensity of exercise on the Borg scale. So we use that to understand their intensity of exercise, since many of these patients don't have a palpable or reliable pulse that could be used to titrate exercise. We could see on the app their perceived rating of the intensity of their exercise. And these patients also completed video calls with an exercise physiologist. So they completed them every 2 weeks for the first 3 months and then monthly for the subsequent 3 months. And that exercise physiologist guided them on their walking and strengthening exercises, helped them use this data on their daily steps and also their Borg rating, and followed some flow charts to help determine what their next goal would be and continue to try to increase their exercise prescription. And what we found in this study of 20 patients, 10 randomized to the home-based exercise arm and 10 in the usual care, is one, that it was safe. So the home-based exercise rehab protocol was not associated with any adverse events. No patients went to the emergency room or re-hospitalized because of the exercise program, since it was self-limited exercise. We noticed that there was a significant increase in daily steps from week 1 to week 6 to month 6 in the home-based exercise rehab group compared to those in usual care. So those in the usual care group, from the time of starting the study to the end, they stayed in the range of about 1,500 to 2,000 steps a day, whereas those in the home-based exercise rehab arm were able to increase from about that 1,500 number to about 4,000 steps at the end of the study. And these patients not only did walking exercises, but they did some also simple upper body and lower extremity exercises using light weights, so 1, 3, and 5 pound weights, as well as resistance bands. So light and moderate strength resistance bands for their upper extremities and lower extremities. And we also looked at rehospitalizations. And again, this is a very small sample, but what we saw a signal towards less rehospitalizations in the group that was participating in the home-based exercise rehabilitation. So with this data, we actually used that data to apply for NIH funding for a study called the Move LVAD 2 multi-center study, which we started enrolling in a few months ago, and so far have had a very good experience with across the sites. So we're collaborating with multiple sites across the country. And in this study, we have 80 patients randomized to a similar program, exercise intervention versus usual care. But here we're not only looking at steps, but we're also looking at measures of frailty and sarcopenia. So we look at multiple freed frailty criteria. We're looking at that pectoralis muscle quantity that I showed you in a previous slide, quality of life, and we're also doing a cost analysis. So we're partnering with health economists at the University of Pennsylvania who are helping us to better determine cost effectiveness, healthcare utilization in both groups to see if this is something that can be implemented on a larger scale. So not only are we working on optimizing patients in the clinic, but we have also spent a lot of time optimizing our preoperative and postoperative protocols. So we created enhanced recovery after surgery protocols specific to the VAD population. And this helps collaborate across multiple services. So we collaborate with our dietitians, our endocrinologists, our physical therapists, the ICU, to really work on optimizing pre and post-operative nutrition, early mobility, and early extubation. And with this protocol, we not only have protocols that are created through Epic, but we also have flow charts that we use when we're rounding. So we make sure that different criteria are met for these patients every day. So we continue to move these patients through a standardized protocol. And this has really helped our ICU accommodate to increased volume of VAD recipients, make sure that everyone is staying on the same page, and reduce that length of stay. We also have thought a lot about our operative strategies when we're thinking about how we can optimize patients. So we're doing, having our surgeons are implanting VADs more and more through a thoracotomy approach instead of a traditional sternotomy approach. And what we have found, again, we need more data on this, but it seems that the less invasive strategy with the thoracotomy approach has improved postoperative hemodynamics. So we have found that these patients who undergo the thoracotomy need a lower amount of vasoactive agents as well as inotropes post-op while still maintaining the same hemodynamic goals. They have a reduced risk of right heart failure and RVAD use, potentially because when we use this thoracotomy approach, we're able to maintain the heart in its natural anatomic position during the surgery and preserve both the pericardium and the sternum above the RV. So again, this is an area where we need more data, but we have also been using this approach more in this population. So overall, as I told you, to really optimize these patients before transplant, we've been working on a number of strategies in the outpatient area, as well as intra-op and post-op to really fine-tune those protocols, make sure these patients are well optimized before and after implant and during the long term. But when we think about how we can optimize outcomes in patients being bridged to transplant, we also need to think about our donor strategy. So one major issue that we deal with in patients who get an LVAD and who we are considering transplant is sensitization. So often these patients have undergone a number of blood transfusions, and as a result of the immunogenicity of the device itself, we can see an increase in cytokines during implantation, which leads to more sensitization. So this is a study that came out of Dr. Kobashigawa's group looking at sensitized VAD and non-sensitized VAD patients compared to those who don't have a VAD. And what they found is that those who are sensitized and have an LVAD, despite the fact that they're sensitized, their 1-year freedom from AMR was similar to those who are non-sensitized with an LVAD or non-sensitized without an LVAD. So it seems that these sensitization is less of a poor prognostic factor in this population compared to those who are sensitized and don't have a VAD. And so not only did they notice that, they also noticed that in this population, the PRA decreased significantly post-transplant. So it seems like removing the device itself really helped reduce this sensitization status. So if we're trying to further risk stratify these patients, and at our listing meetings, we're presenting a patient thinking about whether this VAD patient should be listed for transplant. We notice that they have a higher PRA. The other thing we look at is donor-specific antibodies for risk stratification. And another thing that Dr. Kobashigawa's group found was that in patients who had an MCS device but did not have any donor-specific antibodies, these patients seemed to do better compared to those who had an MCS device but had donor-specific antibodies. So again, this is another method that can be used to risk stratify these patients. So if they're sensitized but they don't have DSAs, then this is the population that will have reduced risk of AMR and could potentially be successfully listed for transplant. In certain select candidates, we've also discussed desensitization strategies. So using rituximab and IVIG or plasmapheresis with Velcade in this population. And again, this is not without risk. This population, as I showed you before, already has a higher risk of primary graft dysfunction. When you add desensitization strategies on top of that, you can further increase that risk. There's always a risk of infection as well in this population, particularly as related to the driveline. Other risks and adverse events related to desensitization itself, including neuropathy. So this is something that has to be done in very select groups, but in appropriate candidates, this can be successfully performed. And, what Dr. Kobashigawa's group noted was that there was a, higher reduction in PRA in patients who had an LVAD and underwent desensitization compared to those who did not have an LVAD and underwent desensitization. So again, suggesting that sensitization status in VAD patients may not have quite as high prognostic value as it does in patients who don't have an LVAD. So we can also think about using our newer technologies when we are transporting our donors. So many of you are probably familiar with the Sherpa PACC cardiac transport system. This helps maintain the donor heart temperature between 4 to 8 degrees Celsius. So this is like fancy ice, basically, okay? And so we have been using this routinely in all our patients who have an LVAD and are undergoing transplant. It does increase the cost of transplant, but in this study, you can see that patients who had a durable LVAD who underwent transplant using the Sherpa PACC cardiac transplant cardiac system instead of traditional ICE, they had a lower risk of post-transplant severe primary graft dysfunction, and there was a signal that they had better post-transplant RV function. And another study was also showed similar outcomes. So this is a study looking at patients who had an LVAD undergoing transplant via that Sherpa PACC fancy ice versus cold storage. And there was a signal towards improved survival in the VAD patients who used Sherpa PACC versus those who only received cold storage for their graft. And the other thing that they noticed most importantly, because now we're traveling farther, right, to get hearts, is that patients who, despite traveling farther for the heart, despite having longer ischemic time, there was still a lower risk of primary graft dysfunction in the VAD patients who received their graft via Sherpa PACC compared to cold storage. We've also been, making sure that all of our patients who are appropriate candidates for transplant who have an LVAD in the outpatient clinic are also consented for DCDs, donation after circulatory death, because this seems to be another way to get patients who have a VAD, allow them to get a transplant earlier than they would have to wait in traditional DBD donor. So this is data, that was published recently in Journal of Heart and Lung Transplant, looking at patients who receive DCD heart, so about 400 patients versus, DBD heart, a much larger population. But you can see that there's a larger percentage of patients who are listed status 4 who receive a DCD heart. So again, the current allocation system prioritizes those patients who are sicker, who are status 1 or 2, who are listed with temporary MCS, and often the VAD patients who are status 4 are not prioritized. But this is the population that may benefit more from DCD. And you can see also that about 40% of the patients who underwent DCD in this population had an LVAD versus only 32% in the DBD population. So again, this is an opportunity to perhaps get patients transplanted more quickly. We've done a couple of DCD transplants in patients who have LVAD support. They've done well. Again, our team continues to improve because this is a complex surgery. And then when we look at outcomes, DCD versus DBD, again, this is an area where we as a field are collecting more data. So when we look at overall graft survival, there isn't significant difference between the DCD versus DBD cohorts. And then when we look at VAD patients specifically, again, we don't see a significant change in effect on mortality by having preoperative VAD support. In fact, it just seems like the traditional risk factors for post-transplant mortality, like mechanical ventilation, are affecting survival. And finally, combined transplant. So we know that overall, in this current area, outcomes after simultaneous heart-kidney transplant are worse post the allocation policy changes compared to pre-changes. This is, again, an area where we're collecting more data, but this is probably due to the fact that we are transplanting sicker patients who are more likely to be on temporary MCS, including ECMO support, are undergoing heart-kidney transplant. They're not doing as well. But we definitely see that in the VAD population, those who undergo combined heart-kidney transplant, their mortality is worse post-policy change than pre-policy change. And there are a number of contributing factors, including the fact that these patients who are undergoing transplant usually have a complication, including late right heart failure, hepatic congestion, coagulopathy. There's, again, the systemic influences of prolonged LVAD support, including vasoplegia. All of these affect post-transplant outcomes. So this is, again, an area where we need to continue to be more refined about our decision-making, consider if patients perhaps instead should just get a safety net kidney transplant, get a kidney transplant after their heart transplant. So this is something, again, that we need to further consider. But DCD is being used in this population as well. And again, we need more data. But in this particular cohort, there was an increased percentage of patients, about 24% compared to 14% who had an LVAD who received DCD heart kidney transplant as opposed to those in the DBD group. So again, more to come in this area, but this might be a way to have our patients who have a durable LVAD be able to be transplanted, undergo heart kidney transplant faster by using a DCD donor. But overall, to really allow us to make transplant for LVAD patients a reality, we really need to change the OPTN proposals and allocation system. So this is a proposal that's currently under review and available for public comment. So in this proposal, adult heart candidates supported by a LVAD for extended periods of time will be eligible to transition to status 2 or 3 if they've had an LVAD for 6 years before or longer, they'll be eligible for status 3. If they've had an LVAD for 8 years or longer, they'll be eligible for status 2. And then 18 months after implementation, OPTN is proposing that the timeframes will be shortened. So to 5 years, patients who have been supported by a LVAD for 5 years will be eligible for status 3, and patients who have been supported for 7 years will be eligible for status 2. And so this is a step forward, but again, this is probably not far enough. This, really doesn't affect those patients who have been supported by a VAD for a shorter duration of time, who have started to develop a little bit of aortic regurgitation, a little bit of right ventricular failure, a little bit of, worsening renal function. These are often the signs that things are going to get worse, who, are right within their window to be transplanted, but who are unable to actually meet the criteria for upgrade in status. So it's while this is a step in the right direction, it still does not include all the factors that we really need to consider when we're trying to determine if we're able to upgrade our patients on the list so that they can be transplanted faster. So more to come, I think in the future, as this is an evolving area, as we see this improve, I hope that as a heart failure community, we will be able to better determine who should get an LVAD, perhaps those younger patients who have better right ventricular function, better end organ function, who can get an LVAD, be successfully supported for a number of years, and then get a transplant. Hopefully, we can make that a reality as we continue to refine this allocation system and move towards improved system that will allow that increase in priority. So with that, I wanted to thank you all for your attention, and I welcome any comments or questions that you might have.
Thank you for a wonderful talk, and we have plenty of time for questions. We'll watch for questions online too. Keith.
Mesmerized, because it's not like the Gates building, right? Thanks so much. Question about the home rehab.
Yeah.
So, are you going to continue to follow them for steps, polylife and all that, after the exercise physiologist intervention ends?
So yes, so it's a 6-month intervention, and then we follow them for a total for a year to see what is the longer term benefits of it. Yes, absolutely.
Second, it's going to be part of it. Funding, sort of putting it into practice.
Yes.
Maybe you can research in private. I would hope that you train them to exercise like it.
Yes, and actually, so what we have done, because not all sites have an exercise therapist who is funded for research, So we have a exercise therapist at Penn who's kind of lead therapist. We created all the protocols, exercises, videos, and then at each of the sites, we actually have slightly different models, which is very interesting. So for example, Utah, they have a research coordinator. Cleveland Clinic uses a VAD coordinator. And Henry Ford has an exercise therapist who's using it. So we have slightly different models, and we meet monthly, make sure that we collect a lot of data in REDCap to make sure that everyone's following a standardized protocol, giving patients the same prescriptions. We meet monthly to give each other advice. And so the hope is that this kind of program will eventually be implemented without having to actually need a trained exercise physiologist or therapist to do these exercises. And we have a number of flow charts that we created through the pilot study, looking at, what step goals should be, how much, percentage change it seems to be normal to expect in patients. So we have some guidelines so we can look at the steps, look at the progression of a patient, and then determine how should we change the strengthening exercises, how should we change the walking prescriptions to standardize this as much as possible.
Right.
Thanks for a great talk. I also wanted to ask about the home-based exercise program. One of the challenges is the watches only work when you wear them and when they're charged and whatnot. And if one group is getting more attention, sometimes that leads to longer wear times more consistently. Did you observe that? And how do you address that in studies like this?
Yeah. Very good question. And when I did the pilot study, I finally understood why NIH really wants so much pilot data, because I wore multiple watches for multiple weeks, and I finally came across a watch actually that was used in a study in Europe, a Garmin watch that actually doesn't require, it can last for 1 year without being charged. And it's waterproof. So we've just had our patients actually just put it on and tell them just wear it, don't take it off. So majority of our patients are doing that. Because since it doesn't need to be charged. And then to control for attention, what we have done in the usual care group, because they also get the watch and the app, is we have short phone calls from the research coordinator, just checking in, making sure that they're wearing the watch. It's a very refined phone script that they use, so that that partially helps control the attention for in between the two groups.
Excellent talk. Thank you very much. What do you think the mechanism is by which DCD hearts are allocated more frequently to LVADs? What is that must be implicit in the decision-making process? And I'll let you answer that, and I have a follow-up question.
It's a very good question. I think part of it is one, currently the patients who are listed status 1 or 2, waiting often on temporary MCS devices, usually Impella. These patients, we've been able to get a heart generally more without having to travel farther and use DCD. So, one is that. So then, the patients who are lower on the list, so status 4 patients, those are the ones who are being offered these DCD hearts that you have to travel longer distance. 2 is, I think this will, if I gave this talk in a year, I think this data will be different. I think that 2 is just, as a community gaining experience and thinking about when we review these donors, are we ready to take a DCD heart for our patient who is waiting on ECMO or, sick in the hospital, versus somebody who's a little bit healthier at home, maybe we can go and take that heart. So some of it is just center-based practices. And we've seen our own center, since we started implementing DCD, starting to take that little bit more risk, being able to feel more comfortable about who we use it in.
So is it fair to say, at least for the short term, DCDs are viewed as inferior? And if so, or a higher risk if you prefer, and if so, what would provide your team with reassurance that it was in fact equivalent to DBD?
Very good question. There's more and more data. I feel like there's, papers at least every month coming out in this field. So far, outcomes seem similar. I mean, you can divide up DCD into the type, how you're doing it on RP versus DPP, and, try to see which one is better. But I think overall, the outcomes have been reassuring. I think it all depends on teams developing experience. So the more your team does it, if, we work with Keystone and other procurement services as well. So becoming more comfortable with them, their techniques. As the team becomes more comfortable, outcomes improve.
Questions? Any online questions? Well, yeah.
Thank you so much for that great presentation. So I had a question about destination therapy.
Yeah.
And you've mentioned a few times that the outcomes of LVAD therapy are improving compared to where we're starting. What do you think is missing to stop talking about bridge to transplant to be pursuing an LVAD as an option rather than transplant? What is missing in maybe the technology, the outcomes?
So I think there's two factors. One is provider and one is patient. Okay. So if we think about the patient factors, so, still patients have a driveline coming out of their belly. And so, we eventually as a field would love to work towards a fully implantable pump, but the technology is still not there, particularly for charging and so forth. We need companies to really work on this. And this is something as a heart failure community. You guys are involved in the BrioVAD study, for example. So, trying to increase competition in the area, trying to really force, companies to really work on improving that technology is important. So one is just the device itself. Okay. Two is the providers. So, one thing we noticed among our group is that when we started referring patients a little bit earlier, right when they started, milrinone therapy, instead of waiting multiple months, or when less sick patients started going into VAD implant and coming out looking better, they leave the hospital within 2 weeks, they look good in clinic. Our group of heart failure faculty started to embrace the technology more, themselves, and say, hey, what, patients are doing well. This is something that I feel like I can honestly go to my patient and say, hey, you will do well with this, consider this therapy. So I think there's both patient and provider factors. At the end of the day, it's still in a situation where it's 2 surgeries. So, you get, the VAD, and then you're going to be getting another surgery transplant. So like I discussed, trying to refine that process, there's always the risk you're taking instead of just one surgery. But I used to previously run a transplant program. So I think of myself as a equal opportunity heart failure doctor. Transplant is no picnic either. On the other side, there's complications there too. So with each patient, I think it's really a shared decision. Again, my surgical direct partner and I, we both are in both the heart transplant and the VAD space. So we really spend a lot of time talking to patients and trying to, particularly the younger patients, trying to weigh their options. And we've seen both things. I've had young patients come to me and say, I want to get a VAD. I read about this. I want to get a VAD. I want to do a couple of years on the VAD, and then I'll go to transplant because I'm only 32. And I want to get a couple of years on this, and then let's start the clock on transplant. And then there's others who will say, I love showering. I love swimming. I'm not doing this. So.
Modeling,
Yeah.
a trial, the people who remodeled and were able to get their VADs out for a while were the young people.
Yeah.
So really, maybe the strategy is VAD, optimal medical therapy, get the VAD out for a while. It's going to recur, but get it out for a while, then get transplant.
No, I think
VAD
that's
and transplant. So really, we don't have years without a VAD would be good years.
That's an excellent point. Recovery, that's another thing with these younger patients that we discussed. We had Stavros Drakos come and visit us recently, and he's a real believer in recovery. And this goes back to optimizing guideline-directed medical therapy in these patients. We may not be able to recover everyone, but if we can even get some amount of partial recovery, it helps reduce the risk of right heart failure, GI bleeding, and so forth in the long term. And so, again, trying to find that optimal regimen for patients so that they do well long term, regardless of whether they fully recover or they continue in VAD support, is important.
Okay, well, thank you very much for a wonderful talk, and thank you all for coming.